Other questions or comments? Okay, thanks a lot, Esther. And the next speaker is Dr. Jordi Serra from Neuroscience Technology. He's a medical doctor at neurology specialist and has worked with pain for many years. And I see you've always also been involved in pain diagnostics and how to classify the disease. So maybe we can get some of the answers to the challenge here.
Okay, thank you. Thank you very much for the invitation. I know I have a tough job now because it's too late. I have to hurry up. And you are probably a little bit tired and probably on pain, which is what I am going to talk about. So I am here to represent Europain, which is one of the first consortiums that was made within the IMI project or initiative. And what's the problem? And we received a set of slides that was very accurate and to the point, teaching us what we should say during this talk and what we should deliver. And I will try to stick to it as much as possible, but I think that we will all agree that we are on pain. We are on pain because this is a frequent thing. 1 out of 5 Europeans suffer from it. And we have different types of pains. We have acute pain, we go and have an accident, and we have acute pain, we go and have surgery, and we have post-surgical pain, and we can more or less treat this in a proper way. But then we also have chronic pain. And chronic pain is a very special thing. It's a very special condition. It's so special that we would say that it's a disease by itself. And this is something which is difficult to understand, because many people think that pain is something like fever. So I have fever, and fever belongs to a disease. So I have pain, and pain belongs to a disease. So I have a stroke. That's a cardiovascular disease, you know, and pain is part of this. And I have multiple sclerosis, and then I have pain, and this is part of this disease. But this is not really true. Pain itself is a kind of disease. Once chronic pain is there in our bodies, it behaves in a kind of autonomous way. Within these chronic pains, there is a very special pain, which is neuropathic pain. Neuropathic pain is the pain that comes when you have a disease of the nervous system, either the peripheral or the central nervous system. When you have these conditions, you cost a lot of money, really, to the society, to your families, to yourself, but also to the society. And there are lots of studies quantifying how much money this represents. And just to make an example, I mean, we know that #1 cost is for psychiatric diseases, but pain is the second one. It's not cardiovascular, it's not, other types of diseases, degenerative disease, it's pain. So Europeans, the second most expensive things that we do to treat our patients and our populations is to spend money on treating pain. And this is still a high, an unmet need. Only one third of the chronic pain patients really have adequate pain relief. And if you think about that, that's amazing, you know. So, which is the key research challenge behind Europain? Well, it's the answer to these questions. Who wants to suffer? And I think that's very simple. Nobody. Nobody wants to suffer. So only this tells you how important Europain is and how important are the efforts that we are devoting in trying to understand pain. So Europain, it's a consortium whose main aim is to understand the mechanisms behind pain, and also to improve the treatment of patients by developing new drugs. Why is it so complicated? And I'm a neurologist and a clinical neurophysiologist, and I also serve as a CSO of a small medium enterprise. So I have a leg on both sides. I see patients myself, I understand patients, and I understand which is the problem, and I also see which are the challenges in the industry to try to develop new drugs. So the problem is very complex. It's complex because there are so many patients, 1 out of 5, it's a lot of patients, and so many etiologies that can cause this chronic pain. So you may have diabetes. You all know how prevalent diabetes is in the European population. And you may have polyneuropathy and pain. And then you have young people going with motorbikes and involved in car accidents that have focal traumatic nerve injury. That's very prevalent, and they have pain. Some of them remain in pain. And then you have common things like radiculopathy, an impinged root in your back, and you will have pain. Carpal tunnel syndrome, tingling in your hands and pain in your hands. This is also neuropathic pain. So complicated in a way, so complicated to harmonize and to dissect and to categorize the thing that's making the field complicated. Also, neuropathic pain patients do not have a single thing. They do not come to you saying, I have pain, and that's it. Neuropathic pain patients have many symptoms and many signs and many mechanisms behind these signs and symptoms. And above all, they complain of this thing that we call pain. So they come to you, they have many things, but they complain of pain. And as I was telling you, we are still not treating this in an adequate way. And it's a pity, it's a sorrow. So which is the key research challenge? I think that key research challenges are addressed by asking the correct questions. And I think that one of the correct and simple questions in pain, in chronic pain, is why we do not have yet a really good drug for neuropathic pain. It's a simple question. It has been many years that we have been tackling with the problem, many years that we have been producing literally hundreds of papers understanding the genetics, the proteomics, the functional imaging of the problem, but why we don't have good drugs yet. And it's very curious because the two previous speakers, they are saying exactly the same thing. And the same thing is that, first, we don't have anything which is predictive. So we don't have anything in the preclinical setting which is a true predicted biomarker for spontaneous pain. But I was listening the same for some of the psychiatric diseases and some of the degenerative diseases. The other thing is that we have limited knowledge of the critical, and I underline critical, pain mechanisms. Of course we know a lot of pain. Of course we know a lot of Alzheimer's disease. And of course we know a lot of mental disease. But we don't know of all these things that we know, which is the one that's critical, which is the one that we have to address, and we have to go and we have to target to get a good drug. So Europain is a large consortium. It has FPI companies that are listed here. It has academia, and it has a single SME. A little bit of a shy that I am here alone as a representative of an SME. And I hope that in the next future, the proportion will balance a little bit with probably less academia and maybe more FPI and more SMEs. And I say this not because I don't like academia. I come from academia as well, and not because I don't like FPI. I say this because I would say that most of the economical power in Europe belongs to SMEs. Most of the economical drive is within the SMEs, and particularly within research-intensive SMEs. So what we have been doing in Europain, and I don't want to bore you with graphics that probably a third of the people here don't understand, myself included in these people. But we have been delivering lots of things. We have been delivering things at the level of genomics and proteomics. We have been identifying novel targets, novel things that are completely translatable from human and animal, and that we are beginning to explore whether they can become drugs. We are doing interesting things like old-style, old-fashioned electrophysiology that we strongly believe, or I personally strongly believe, is going to be again the future. And we heard about the keynote lecture in the beginning about the Human Brain Project, which relies a lot on electrophysiology. And this is because our nervous system relies on action potentials, on spikes, on activity, nerve activity. And we need to understand this. And electrophysiology is old, and it's old-fashioned, but what we have new now is new mathematical tools, new recording tools, and new data management tools that allow things like this. For instance, this special technique, microneurography. You stick a needle in the nerve of a human, or you stick the needle in the nerve of an animal, and then you induce a disease in the animal, or you have a disease in the patient, and you can record activity in humans and in animals, and it turns out that it's exactly the same on both sides. So what we need is this type of tools that are truly translatable between humans and animals, because this will advance the field for sure. We are also profiling patients. We know that these patients are very diverse. They have different symptoms, different signs. So we need ways of standardizing this assessment, because in the end, not everybody is going to be able to do electrophysiology in a primary point of care. So we will need tools to stratify these patients. There's a big effort, particularly emanating from Germany, in trying to quantify and standardize the way that we assess patients. We are, of course, doing neuroimaging. We are identifying which are some of the key cerebral areas that are involved in pain, and we are trying to identify whether we can predict what patients are going to develop pain. And of course, we would like to have tools to quantify pain, to say how much pain we have. But among all these things, we are also doing the typical things. We are delivering. We are delivering academically and scientifically. We are publishing a lot as a consortium. We are publishing very good papers. We are very active in doing international consensus meetings. For instance, some weeks ago, we had a consensus meeting trying to address the issue of how to conduct preclinical trials, not clinical trials, preclinical trials, how to agree between us on how to do the things so we can standardize it. We are also conducting clinical trials in humans to try to improve patient stratification. We are developing tools to predict which patients are going to respond to treatments. We are trying to understand, and we think we are understanding quite a lot of what's the placebo effect, because the placebo effect is the friend of any neurologist, because I want patients to have a lot of placebo effect, but it's the enemy of the industry, because many of the late-phase clinical trials fail because of these high rates of placebo. And also, we have initiated AMA interactions to try to frame or to try to understand which is the regulatory landscape and how we can help advance medicines for these patients. And this is probably what we are more proud of, and is this. And I will try to go fast on that. So this is the different partners and the initial collaborations and how they have been evolving over the years. And it's only 3 years into the project. So there is a big momentum here of interaction and a big momentum of collaboration between the industry, the academia, and the single SME in this case, but different players in this consortium. And this is my last slide. I wanted to be brief, and I hope I will stick to my time. So there are 2 big challenges here, and I think that one of the challenges that I have listed here is the one that must make us think more about it. And we have operational challenges and scientific challenges. One operational challenge is to integrate the data that we generate. So these consortiums are big. Data, it's in the thousands, in the thousands of bits of information. So we have to integrate this. We have to have continuity of these initiated efforts. And we have also scientific challenges, like finding the true biomarker for spontaneous pain. I think we are on the good track for it. And of course, what we want is to develop potent and effective painkillers, because in the end, our drive is to improve the well-being of patients in Europe. But still, which is the main remaining challenge? And I think the main danger we have here is this one, is the continuity of the initiated efforts. To me, what happens, and one of the big differences between Europe and the US, is that sometimes we build a lot of momentum here in Europe, and then all of a sudden, everything finishes and fades away. So complex things need continuity, and we know that need effort, and effort and continuity means investment. So we need continuity, because otherwise all this momentum, all these interactions, we are almost there, will fade away in a moment because we finished the consortium and everybody goes home, and we are still friends, but we are no longer collaborating. Thank you very much.
Thank you, Jordi. We will have time for one question before the coffee break. Please. Yes, you. And Mike is on the way.
Thank you, Jim. Professor Linson from the RMNRC Newport Network. A general statement I would like to make, in fact, in response also to Professor Frakowiak. Integration is one of the most complex challenges of today. There is a general consensus regarding interdisciplinarity, but we are still light years away from integrating interdisciplinarity. The existing educational system is not sufficiently powerful to enable us to deal with the complexities of the challenges we are faced with. It is absolutely vital to change to the education of tomorrow, integrating interdisciplinarity. Finally, I would like to say that we have been invited regularly to workshops and conferences at the European Parliament, Commission, and universities. And I made this alarming conclusion quite some time ago. and that is whatever the thematic, the issues raised have reached such a level of complexity that experts, academics, politicians, and the audience are getting completely out of their depth. Why? Because they are faced with an integrated interdisciplinary challenge, something that their education has not prepared them for. Thank you.
Thank you. Thank you very much, Jordi, for a very great presentation. And we'll now take the coffee break and reconvene at 11:45. Thank you.